All right, good morning. Welcome to Project Echo. Todd's going to be doing our talk today. Let me get through a couple of quick intro things and then we'll turn it over to him. Um, Usual statement on disclosure of relationships. No financial relationships to disclose for any of those involved in this training this morning. And our usual funding statement. Um, Sorry, excuse me, I got to let a couple more people in. Grant funded projects. And this is we're obliged to post this funding statement. Okay, the usual process for CME certificates. There'll be a quick link that'll get emailed out. That link will also get posted in the chat towards the end of this session. Just complete a quick training evaluation survey and your certificate will pop up. And as always, just shoot me an email if you have any questions. Just a reminder of where we are in our current Echo series. We do these in bunches of four. So Dr. Massey was last week, Dr. Stoll's this week. Then we've got Dr. Dwork in a couple weeks doing a talk on infectious comorbidities. And then we're finishing out the session with a few of our Echo team members presenting some case studies for special populations. Just wanted to post this up here too. We're going to try something different for our next cycle. We're going to open up for a few guest lectures. That next Echo cycle will be in July and August. It'll be 4 trainings. So if you're interested in presenting a guest lecture, let me know. I've put up some ideas for topics there. Anything specific to your practice or unique to your practice or how your practice has changed with regard to pain and substance use disorder treatment. Anything emerging topics within this realm, complex cases, could include patient testimonials. You could do these presentations individually or with a group of colleagues. And yeah, we're just looking for our usual 40 to 45-minute talk with some time for questions. We do have a modest stipend available to cover people's time to do this. So if you're interested in doing a guest lecture in our next cycle, you've got my contact information there. Shoot me an email or give me a call and we can get you lined up for that. All right, now I will stop sharing my screen and let our Echo panel introduce themselves. Let's see. Alex, would you like to go first?
Sure thing. Alex Dwork. I'm a family physician based in Omaha. I do primary care with a focus on addiction and other underserved medicine.
Thank you. And Ed?
Yeah, good morning, everybody. Ed Kaiser here, nurse practitioner in Omaha, Nebraska, currently in Colorado today for the ASAM conference. So excited for that, but excited to be with you guys. Thanks for coming on again.
Awesome. Thanks, Ed. Um, it looks like we might be missing a few members of our panel. They may be showing up later. So I think that's all we've got. Todd, I'll turn it over to you.
Good morning, everybody. Todd Stull. A few things that I want to talk about up front before we get into the talk today. First off, and I want to circle back because many of you don't know this, and I've been with Echos since the beginning. It started off really slow many years ago, and it has really grown in terms of kind of participation in numbers and so on. And that's largely due to Will. And so I want to thank Will for it's night and day difference compared to the way it used to be. And since Will with the anime has taken it over, so it's quite remarkable. The second thing I want to alert everybody to and make aware of is a clinic called Bonsai. Bonsai is growing and expanding. They are a OTP, they're an opioid treatment program. They're forward thinking. They are in Omaha, but I think they're going to be reaching out into kind of other areas. And so just be aware of the clinic called Bonsai Opioid Treatment Program, and they're growing, and you may see them push out into other parts of the state. Two other things that I want to make the group aware of before we get into our topic today. Within the state of Nebraska, and again, I'm going back to Will, there is a project called Integrated Health. Integrated Health, and it ties in a little bit to what I'm going to talk about today, but Integrated Health is the idea of taking mental health and substance providers and putting them in primary care clinics. The state has, and the state meaning mainly kind of UNMC, has worked on this for years. Joe Evans did some amazing work and was able to put 17 people out in 20 years. The project that we have at the NMA, we have now 20 people that we put into clinics in about 18 months. And so it's been really successful, very well received. Um, it's a project that there was a huge, we did a needs assessment and so on, but the idea was to help the primary care providers throughout the state of Nebraska, especially in rural areas, uh, meet the needs locally in whole health care. So whole health care is physical health and mental health. And remember that many of the issues that primary care providers experience are behaviors related to medical problems, not just psychiatric problems that they're dealing with. And so these behavior problems, whether it's managing hypertension and the behaviors that go with that, or um, addiction kinds of things, smoking, or whether it is managing blood sugars, that mental health provider or that behavioral health expert can be used within that clinic and be very valuable. The final thing I want to mention is a program called Bridges. It's run through the Clarkson Foundation. It is a program that is free CME, and it's training. It's a 2-day, full-day training that runs in cycles um, to train individuals about mental health and substance, primarily focused on mental health. It is overwhelmingly popular and well received. There's been like 7 cohorts now. There are 7 groups that have gone through. There's, if you're interested, Will may be able to put it on here, or it's on the Clarkson Foundation website. They rotate the trainings. There's, I think, one in July, August, one in July and August, or something like that. I don't remember the exact dates. And so, Bridges to Mental Health, I want you to be aware of it. It is, they stop um, because it fills up. They can't take anymore, so you have to try to get into the next group. That's how popular this program is, and it's of no cost. You get continuing education for it, and so on. So just be aware of those programs, which ties into really the topic for today and what I'm hoping to discuss today. All right. Can you see my slides okay now? Will, you're muted.
Sorry about that. Yeah, that looks perfect, Todd.
Okay, great. So I'm going to talk about something a little bit different today, and it's going to be in a 2-part kind of series. I'll do part 1 today. Today is an overview of uh, personality disorders, and we're going to get into personality specifically with addiction. Within psychiatry, and I practiced about, I hate to say it now, but about 30 years. And I will tell you that, and my opinion is that personality is one of the most complex and challenging things, and probably and underappreciated components of whether it's medical problems, substance, or psychiatric, or the combination of any of those. It is not only very nuanced, but there's a number of variables that contribute to personality. And when you personality disorders, as you like anything, occur along a spectrum. So because of the nature of and when I say along a spectrum, mild, moderate to severe, because of the nature of personality and its huge impact on mental illness or on substance problems, I think we need to review it. I just think there's such a strong kind of influence from personality when it is overlooked. And when personality is overlooked and personality disorders are overlooked, outcomes are not near as good for medical problems, psychiatric problems, or substance problems. When someone has a fairly significant or severe, moderate to severe mental health problem, they're more likely to have a substance problem and vice versa. Well, components of one's personality have a huge impact in terms of what's going to happen with outcomes. So I'm going to review today um, some of the components of personality and describe a little bit about some of the different models. And then we're going to go into a little bit about comorbidity, and we're going to understand the basic features of each personality, and a little bit about treatment. When we get to part two, again, this is part one, we're going to break it down even deeper into kind of the postulates, if you will, or the ideas around why individuals develop substance problems within personality, and specifically the personality disorders that are more likely to present with for someone that has a substance use disorder. So let me say this a little bit differently, because this is the next point I'm going to make. It is one I would like you to remember. If you know, not that I have anything much worth remembering, but this would be one to think about anyway. Um, if someone has problems with managing their life and coping with the world, there is no medicine that's going to fix that. Whether it's a substance problem or a psychiatric problem, um, the medicine may take the edge off of some of the symptoms, but the ability to learn to deal and manage and cope, that's a part of that leads to not only relapse or recidivism, but that's a part that needs to be addressed for many people that have substance or psychiatric problems, if you will. So, what is a personality disorder? It's an enduring pattern that one experiences that deviates kind of from what's accepted within culture. And it starts usually during adolescence, and it's fairly stable over time. It's a pattern that doesn't change in from situation to situation a whole lot. And it's not limited to when someone has a physical problem or a head injury or substance problem or mental illness. And so traditionally, we have thought of personality as affecting four areas. And I'm not saying this position of describing it is the end all be all. There's clearly other ways to look at personality, but the four kind of factors to think about with someone usually having kind of a degree of impairment in a couple or more are, cognition. So the way people perceive the world, their perception is off. Their ability to understand and perceive things is off. Their emotional responses, the range and the intensity and the appropriateness, all are off and off. They have trouble getting along with people. So you may find you have trouble getting along with someone in your life. Um, but if you have trouble getting along, or an individual has trouble getting along with multiple people, that would be more consistent with somebody who has a personality disorder. And then they're impulsive. And remember, impulsivity happens in a lot of different kind of scenarios, whether it's ADHD or other sorts of things. So it's not just impulse, unique being to personality, but these are kind of thought of as the traditional features that we look at right now that are categorical, if you will. So personality disorders, as I mentioned, they're rigid. They start often during early adulthood or adolescence, and they interfere with a person's life, and often the individual doesn't recognize the nature of kind of their experience and what's going on with them, and they tend to project or blame others. And a personality disorder isn't explained better by a physiological state. For example, somebody has a stroke and there's a change in personality and they become aggressive or disinhibited or agitated. That's different than kind of the traditional thought of somebody having a personality disorder. Delirium is not a personality disorder, those kinds of things. So when one's experience goes beyond and it becomes what would be kind of adaptive, and it becomes maladaptive, and it causes functional problems in multiple areas of their life, that's fairly pervasive. Now we're talking about someone often who has a personality disorder. So individuals or patients with personality disorder are much more likely to have comorbid conditions, especially mood problems, anxiety problems, and substance problems. So you treat somebody who has depressive symptoms, and the medicine, if you're using medication, may improve, or cognitive behavioral therapy may improve some of the depressive symptoms, but the maladaptive features need to be addressed as well. And remember, this illustrates the point as well that um, the some of the you don't hear it much anymore, but early on in not only my training and my career, um, and it's unfortunate in my opinion that we don't hear much about this now. We would talk about characterological depressions. Characterological depressions, as an example, are driven largely, not solely, but largely from individuals that don't have the capacity or the ability to adapt and adjust and manage their life, right? And so when you think about the range of kind of functioning within our society, and let me give you an analogy. For years, we thought of intelligence as just kind of cognitive horsepower, um, how bright someone is, how good they are at and can problem solve, or do math and science and so on. And then there was a bunch of studies that realized it goes beyond that, and it goes into kind of the emotional component. How can they regulate their emotions? How do they do regulating their emotions? And now added to that is the ability to adapt to situations that are adjust. So you see this maladaptive component sticking up an awful lot, and it is a feature that is creates problems for individuals that have personality problems. They can't see the world maybe through different lenses. They are inflexible, if you will. They're maladaptive. And you'll find in the general population, when you look at the studies, depending on the personality, 10 to 20% of the population has a personality disorder. Again, it's like hypertension, mild, moderate, or severe. Not everyone is severe, but clearly there are individuals that have personality mild symptoms that under stress they regress. The same thing happens for all of us. It's kind of the way we're wired. If we exceed our capacity or our ability to adjust and adapt and manage things, we regress. So there are varying degrees of kind of resilience or hardiness that we all have. But once that's exceeded, then we start to regress or use more or less adaptive kind of strategies to manage what's going on. So what is personality? It's just personality, not a disorder. It's the total experience that someone has that's influenced genetically and developmentally. So it's the emotional and component, the behavioral component, the cognitive component that all go together. When someone has maybe traits of a personality disorder, not the full blown, they may have bits and pieces or behaviors or emotional reactions or thoughts that are that cause distress or problems for them, but they may not have a full disorder. Temperament, we have tended to think about as our biological influence, what we get genetically determined kind of determines autonomic kind or automatic, excuse me, kind of responses. So, for example, um, one thing that may is novelty seeking or harm avoidance. Those are fairly have pretty strong ties, those two concepts, to genetics and what are passed to us. Character is kind of the totality of experience of psychological and physical and cognitive that starts and it has developmental influences over time. And so its character is a little bit different than the biological wiring. Now, how about if we look at some other models of personality? And there's one that's called the Neo 5. The Neo 5, if you have not heard of it, it is very common in the literature. A lot of kind of psychologists will use this and look at testing, and it's looking at these concepts: the degree of extroversion, or introversion, if you will, the degree of kind of agreeableness, warm and considerate versus aloof and irritated and distant, conscientiousness, right? There's that impulsivity on the low end, and responsible and dependable. It's what I call the abilities, dependability, reliability, accountability, and so on the conscientious end. And then there's the emotional stability, how one manages their emotions through a range of experiences and can comfort themselves and so on. And then openness to experience. And so, um, two in particular are really important to the aging process. Not to say the others aren't, but of the Neo 5, as we age and get older, agreeableness, as opposed to kind of cantankerousness and aloof or irritability or becoming a curmudgeon, if you will, and then openness to experience. Those two really, the individuals that are strong in those areas tend to age better. Now, there's another dimension that I didn't include in the slides here that I at least want to bring up because it's gaining traction, and it's looking at, and less so categorical and more one's experience from a kind of dimensional aspect, if you will. And it looks at really kind of two major areas. One is looking at how an individual identifies themselves and their boundaries and how stable they are within um, various situations. Importantly, how they can regulate their emotions and their experiences, and self-appraisal. In other words, understanding kind of where I'm at and what my role is in this, and self-esteem. And then, within that is finding meaning within kind of life and goals and relationships and so on. But then there's the second part of this other kind of way of looking at things that has the looking at intimacy, ability to connect with others and desire and capacity for closeness. And I've mentioned to this group before about the longitudinal aging study, and two of the most important ingredients tie into this kind of interpersonal intimacy aspect, and that is the ability to have love in your life and maintain love in your life. And the final ingredient, kind of in this other model, is really looking at empathy. And empathy really occurs kind of at three levels. One is the cognitive level. I know I should feel bad for someone else. The other is I feel it. Not only do I know I should feel bad, I do feel bad. But then the third layer of empathy that's often missed, that I think is really important, is understanding the effects of one's own behavior on others. That's a really, really important thing. In other words, how do others perceive you, and you having a degree of understanding that. So that's the other kind of model that's gaining a lot of traction that's out there, that really is a dimensional model, more so than categorical. So if you look, personality disorders kind of run in families, for example, and they're tied to mental illness. So if you have a relative that has schizophrenia, there's strong associations with one of the personalities called schizotypal personality. Cluster B, we'll get into that, has the strongest genetic basis. So that's sociopathy or antisocial personality, borderline, histrionic, and narcissistic. Males are more likely to have antisocial, schizoid, and obsessive compulsive personality, and female are more likely to have dependent, avoidant, histrionic, and borderline. That doesn't mean that males or females can't have other personalities. That's not my point. It's just, if you look at the data, this is what you'll find. There's some studies that show an association between aggression and hormones, and aggression is associated with personality. There's also firing of kind of what are called connectomes. These are pathways that take place within our brain that have to do with, we talk about the salience kind of pathway in addiction, if you will, or salience network. But there's others that are very prominent. You've heard probably the executive one or attentional one network and default mode network and so on. These are pathways in our brain that are activated where neurotransmitters are released. And there's some studies showing that there is some effect from that. I don't want to get too deep into that. And then there's some studies that show fluoxetine or Prozac um, can change sensitivity to rejection and increased assertiveness and maybe help a little bit with stress tolerance and self-esteem. So there is some benefit and not to in some cases with medication. How about defense mechanisms? By definition, when you look at psychoanalytic factors, and this is um, to become an analyst, let me say it this way, that it's the longest course of medical training of all specialties. So neurosurgery is a long time, right? To become an analyst is even longer. And so it's a beyond a residency. And so it's very intense training that you have to go through analysis yourself to learn to become an analyst and so on. So it's the idea of and the last kind of true analyst that we had in Nebraska was a guy by the name of Dwayne Sherwin, truly trained in the analytic, and I don't think he's alive anymore. And so really most of the analysts are on the coast. They they look at defense mechanisms which are out of conscious awareness that surface um, during various kind of behaviors. And the idea is to learn to become aware of these defense mechanisms to try to work with them and modify them um, because the defense mechanisms may be at the crux, if you ask an analyst, of a patient's suffering. So that I think I've given kind of the idea. Developmental influences. Well, here you've got your kind of biological, temperamental, as well as some of the characterological things that factor in. So not only do you have biology affecting this, but then is there for that caregiver of the child, if you think about a guy by the name of Winnicott, he came up with this idea of goodness of fit. Goodness of fit is the idea that there's a good enough match for that child to develop over time, to manage the world, to deal with things, to have to perceive things correctly, to regulate their emotions, to develop relationships, to manage their impulsivity, to develop a healthy sense of who they are and identity and that sort of thing. And this is largely cultivated in the model of goodness of fit by you don't have to be a perfect kind of caregiver, parent, grandparent, whoever's raising that child, but there needs to be a good enough fit for that child to develop over time. And if not, then problems start to emerge. Well, when we look at, in fact, before I get to the screen, when we look at someone developing the remnants of a personality disorder, think about this aspect. When do most substance and psychiatric problems develop? Adolescence. Same time you start to see an emergence of someone who has personality problems. So when personality problems start to emerge, it's often because the individual can't manage their life or cope with things or fit in, or they can't regulate their emotions. They can't tolerate their emotions. They don't have meaningful relationships. I could go on and on. I think you get the point. So they develop, not uncommonly, a substance problem, maybe for various reasons. But in fact, nevertheless, we'll talk about some of those reasons in part two. But it happens during this same kind of time that you'll see the emergence of um, psychiatric problems or mental illness and substance problems. And remember, we say that when someone has a mental illness or a substance problem or pain, let's take pain because pain is common, we try to address all of those at once because we know that if they're not, relapse goes up. If it's a substance problem or exacerbation of mental illness takes place, same is true of someone who has personality problems. You want to address, you can't expect someone to their symptoms to go down, and then them to have the coping strategies or ability to manage the world. So here's a screen. I'm not going to read you the questions. You get the idea. The ones that are in bold, which are the answers that are in bold, as far as yes or no, all of them being bold except for number three, um, tend to indicate a more likelihood of personality. You want to look at someone who has a personality disorder not as a snapshot, not they walk into your office and say this person has a personality disorder, but you're looking at patterns over time and often getting collateral or additional information, and you're seeing kind of the struggles that they go through in various aspects of their life with thinking, with their emotions, with their relationships, with their sense of who they are, with their ability to kind of relate and connect, those patterns in various settings affecting their function. And this just starts with the screening process. So when you're screening for someone who has a personality disorder, you want to think about some of these 8 questions, if you will. And I think you'll have access to this if you're interested. But it is it gives you a starting point. And the world's not built on screens, but as I've mentioned in the psychiatric and substance world, our vital signs, our initial vital signs to help start a decision point rest with, in part, doing a screen or a screen and gathering collateral information. And you've heard me say this, and I'll say it again, psychiatric problems in general, not all, and substance problems in general, not all, are family problems. And I think it's best to try to include the family because they're an ingredient to one of the major or key components to outcomes for that individual. Okay, let's dig in. Let's run through these. I've made it kind of so that you can see the bullet points of each kind of personality. We're going to talk about right now in 3 clusters. Some of you may be fully aware of all this, and it's a review. Others may say, "Oh, I've seen it before. I don't remember it," but I want to run through it. I want to create kind of a basis and a background to operate from so that when we get to part 2, you'll have a background from part 1 to say, "Oh, yes, I know what, kind of the key elements are of schizotypal personality or borderline or what have you." So cluster A is referred to as the odd or eccentric cluster, paranoid, schizoid, and schizotypal. Cluster B is the erratic, dramatic. Has 4: antisocial personality, borderline, histrionic, and narcissistic personality. Cluster C is anxious and fearful, which includes avoidant, dependent, and obsessive compulsive. And then there are other kinds of ways to look at personality that we're not going to get into today. Now, I want to go back to something that happened years ago in psychiatry, and I think it's unfortunate that, from my perspective, when I think about seeing a patient, as a psychiatrist, I want to think about that whole individual, the biopsychosocial, cultural, spiritual, whatever developmental, whatever pieces that are important. I want to conceptualize that individual and try to understand their experience and their life as possible. We have gone in psychiatry to a path of pharmacotherapy, which is, I think, 20% of psychiatrists now that see patients do psychotherapy, and that's a small number. It's very unfortunate because you're missing. That'd be like giving somebody insulin and calling it good. That's a type 1 diabetic, in my opinion. There's so much more to type 1 diabetes than putting someone on insulin. Yes, it's an important component, but there's much more to it than that. So I bring to you the idea of, and many of you maybe learned this way back when, the 5 axes to look at someone. So axis 1, and we abandon this in psychiatry. Axis 1 is psychiatric problems, mental illness, if you will. Axis 2 is personality disorders. And so both of those are lumped together now under just assessment, or, if you will, axis 1. There's really not even technically probably an axis anymore. Axis 3 of those 5 axes are medical problems. So, it helps me understand somebody who's got, diabetes or cancer or heart disease or whatever, and how those variables, it reminds me and contextualize how that individual is, what the experience they're going through. Axis 4 are psychosocial things. So this is really, really important. If you look at patients across the spectrum, the number one thing from studies that individuals and across the spectrum want to have in their life is not medication. It's not a doctor. It's not a mental health provider. It is, do I have a place to sleep? Do I have food? And am I safe? Those things stick out over and over and over. And so Axis 4 has things like, do I have a place to sleep? Um, do I have food, clothing, shelter, support? Am I safe? Do I have a job? What about my financial status? Those kinds of things. So it reminds us of that. And then Axis 5 is what's called the global assessment of functioning. And this gives us an idea, a number from basically a 0 to 100 in terms of how someone is functioning. And there's GAF, or Global Assessment of Functioning, is a great thing to kind of have in your mind to say this is one's experience and what they're going through in their life. So think about that a little bit. Look up GAF if you're interested or haven't heard of it, and it gives you a kind of a, oh, this is where they're at. Okay, let's dig into each one. We're on cluster A now. Cluster A, paranoid personality. This is pervasive trust and suspiciousness and interpreting others' motives as bad or evil. Someone's after you. These individuals are grudge collectors, if you will. They focus on distrust. They feel attacked. They won't confide, and they misinterpret. There you go, that kind of cognitive piece. They misinterpret kind of what's being said and motives that are out there. So you need 4 of these over a persistent pattern. Remember, we're talking about patterns now in various settings over time with all personality disorders. So this is paranoid. Schizoid, these are individuals that like to be alone, and a person is kind of like a chair to them, if you will. They're not interested in sex. They live solitary lives. They're night watchmen. They're cold, aloof, indifferent. They don't enjoy activities with others. They don't choose to be around others. They're perfectly content being alone. They have no real close friends. And again, so you see this distant, kind of aloof, detached pattern for this schizoid under cluster A. And last one under cluster A is schizotypal. Again, these individuals have relatives that are often have schizophrenia. These individuals are odd, peculiar. They have ideas of reference or magical thinking or odd thinking. They have strange speech. You feel awkward around these individuals. They'd be talking to you and in a conversation. The next thing you know, they'll say, well, I think I'm going to buy some land in Arizona. And uh, your Aunt Gladys was wearing a funny nightcap the other night. And they say just odd things that aren't really connected, but they're not truly into the realm of fully being psychotic or having a psychotic disorder. Under distress, this group that's can get paranoid and regress into psychotically proportioned behavior. They can hallucinate, they can become delusional. Um, and so this group, you'll know, you've been around individuals that have kind of a strange affect. They'll laugh when things aren't funny, or they'll kind of cry, or have an unusual emotional response when it's not appropriate to the situation. They may dress different and so on. So magical beliefs, as I mentioned. So this eccentric group will stick out in your mind. And we'll come back to this group in part 2. All right, so and this is just basic foundation. Psychotherapy for all is the treatment of choice for all personality disorders. And you're going to see that for every cluster I put here. But I want you to realize that's the backbone. Establishing trust is really important. For this cluster A group, you don't want to put them into group therapy initially. Maybe down the road, they'll be able to tolerate it. But you got to build trust and rapport, and it goes very slowly with this group. In general, pharmacotherapy is used to treat other comorbid psychiatric or substance problems. So in general, pharmacotherapy, if it's used, is to treat comorbidity or co-occurring problems. All right, let's get into cluster B. Sociopathy or antisocial personality. You have to have conduct disorder before the age of 15. Conduct is setting fires, lying, cheating, stealing, running away, skipping school, those sorts of behaviors, cruelty to animals. And then once someone turns 18, they often and have the same kind of behaviors. Then if they're, lying, cheating, stealing, impulsive, they're reckless, and irresponsible, and don't have remorse, then they may have antisocial personality. The thing to remember that's really, really important about this group is they are con artists. And I hate to say it that way, but that's how it's put in the literature. They can manipulate others, and others don't know they're being manipulated because these individuals can be warm and charming, although they can be quite abrasive and antagonistic, but they don't have the capacity to lack remorse, or they have limited capacity, and they know right from wrong, but the rules don't apply to them. Interestingly enough, not only does this group develop a lot of substance problems and have fathers that have substance problems, it's very common. There's a strong genetic association with, again, this antisocial occurs more common in males and their fathers having substance problems, but they can have somatization or somatic symptom disorder. It's very, very common and often overlooked within this group. And so they can have a lot of kind of physical complaints that are unexplained by medical problems. Borderline got its name from being on the border or between neuroses, that's worry, nervousness, anxiety, and psychoses. It can happen in males, but it's more common in females or women, girls, adolescents, often have and come from, not always, unpredictability and unstable relationships and that lack of goodness of fit. So they fear abandonment. They have unstable relationships. They have they struggle to figure out who they are and where their place is in the world, and they're often very moody. This is often mistaken for bipolar disorder. Doesn't mean you can't have both, but it's not the same, and the treatment is not the same. And it is often, individuals often are diagnosed to say they have bipolar and they do not. It's borderline personality, or they may have both. But these individuals feel empty and angry, and they're impulsive, and they have varying degrees of suicidal thoughts, plans, or intentions. They often have self-injurious behaviors, which doesn't necessarily mean they're suicidal, but they may want to feel, or they don't. They feel like they're not feeling something, so they cut on themselves to feel. There's some really great treatments that I'll mention here in a minute for that group that have emerged over time. Histrionic, this is the dramatic theatrical group. This is the patient I had that walked in that would wear low-cut tops, mini skirt, huge earrings, lots of jewelry, came in with her suitcase and said she's not doing well, and was not actively a threat to herself or someone else, and said, I need to go to the hospital. I said, I'm not sure that's the case. This was early in my career. And she proceeded to decompensate, cut on herself in front of me. And then it was time for her to go to the hospital at that point in time. So they need attention. They're the kind of need to be recognized. They're not that Norm is histrionic, but it's the idea of when Norm walks into Cheers, everybody says Norm. They need that kind of recognition and attention, and they have an impressionistic kind of style of talking. If you've ever seen the movie White Chicks, the way they talk in the movie is that impressionistic kind of theatrical, dramatic sort of nature, and that's exaggerated, obviously, but that's what you'll kind of see with individuals that have histrionic personality. They need to feel special and important, but they're not really interested in kind of a sexual relationship so much, but they dress seductively because they want to draw attention to themselves. And again, I'm speaking in generality, so there's obviously lots of kind of nuances that vary from one to another, and so I don't want you to think what I'm telling you is the end all be all. And a narcissistic personality, I think of it as kind of the E's. They're entitled, they're exploitative, they lack empathy, and they're very envious of others that have things that they desire. They have an intense need for admiration. They struggle with empathy, and they're arrogant. There is a spectrum for narcissistic personality that there's some that are very fragile, and if they have too much of an insult or blow to the kind of their coping or their world, they decompensate and can end up in the hospital or end up suicidal. Um, they may end up with having substance problems. This group needs, they fantasize about being the greatest. They're grandiose, and that's kind of the second type. So there's the vulnerable type, if you will, and you can fluctuate between these. Then there's the grandiose type. They're often oblivious to how they are and their entitlement and how they exploit others and take advantage of others. And this group often can provide energy to a room, but the world stops kind of with their thinking with them. It's not about others. They may try to convince you it's about others. It's not about others. They lack the capacity to go beyond kind of themselves. They have what I call kind of noisy desperation. They're frantic in their search for others to admire them and validate their specialness. And they never want to be humiliated. And they're arrested in a stage of development where they require responses from persons in their environment to maintain a cohesive sense of self. They can't soothe themselves, so they need that loyalty and that feedback to create kind of a sense of who they are externally. They don't have it internally. They don't have the capacity. There is also a when narcissism progresses, it gets into what's called malignant narcissism, and malignant narcissism has sociopathic kinds of tendencies. So not only these individuals can be paranoid, but now they do things that you would expect: lie, cheat, steal, exploit others, treat others very poorly, and again, don't have, so they get into sociopathy. And if it goes even further, there's something called the dark triad. The dark triad includes narcissism, the idea of things, it's all about me, if you will. Machiavellianism is the second part of the dark triad. So narcissism is the first part, and what I've gone through here. Machiavellianism is I'm willing to hurt you and to get what I want. And the third part of the dark triad is psychopathology, and that is I feel no empathy and no remorse when I victimize you. And so that's referred to as the dark triad. So narcissism is, and for those of you that are interested, there's been a lot of literature and studies that have come out in the last 10 to 15 years, and work, especially by Twenge is, I believe, her last name. I don't have it in front of me here, but there's some interesting literature on it. So how do we treat cluster B? Psychotherapy again. Antisocial individuals do best in therapeutic communities where you've heard of those when we talk about substance use therapeutic communities where people kind of hold each other accountable. Borderline personality can benefit from psychodynamic psychotherapy and social skills, as well as dialectical and behavioral therapy, which there's pretty good data to show that individuals that have borderline personality that stick with therapy can show some improvements. Pharmacotherapy is directed at, again, comorbidity, right? Also, sometimes medicine can be effective for the reducing anger and explosiveness or aggression. We were into cluster C and on the home stretch here for an overview of the traditional way of looking at personality disorders. There are 3 in cluster C. Avoidant personality, these individuals, think of them as they feel inadequate across the spectrum and settings. They are sensitive, they're shy, they're inhibited, they avoid social contact unless they feel like they're going to be accepted. One of the things that sticks out in my mind about this group is they have an inferiority complex and they fear criticism. So inferiority complex with the fear of being criticized or being accepted. They fear intimacy because they think they might not be accepted or they'll be rejected, and they do not want to be embarrassed, so they often avoid activities. So you say, well, geez, this sounds somewhat like social anxiety disorder because they do share some similarities. Avoidant personality is characterized more so by a pervasive social inhibition and feelings of inadequacy, though, and really a keen or hypersensitivity to negative evaluation. They don't want to be rejected, and in various settings. Whereas social anxiety is an anxiety disorder where individuals experience intense anxiety in social situations. They don't want to draw attention to themselves because they feel like they may be embarrassed or humiliated, but it's in those social situations. A key difference involves the pervasive pattern then of the social avoidance across various aspects with avoidant personality versus specific situations with social anxiety. Dependent personality, the next one under cluster C, these individuals want to be taken care of. You will find, sadly, that and it's not just women, but more commonly women that are in abusive relationships will stay in that because it's more stressful for them, if they have dependent personality, to be alone. They fear solitude. They do not want to be alone. They don't want to disagree. They will take on tasks or jobs that others don't want to do. They fear abandonment. They don't like to make decisions because they don't want to be left alone or rejected. They seek nurturance, and so they're frantic to be in a relationship, and so that and individuals with dependent personality, like avoidant, um, again, and I'll talk about it here in a minute a little bit about the treatment of choice is really psychotherapy. Obsessive compulsive personality disorder is different than obsessive compulsive disorder. Obsessive compulsive disorder is the idea of people have ideas, thoughts, urges, images that come into their mind over and over and over, and they may be silly to them. And then they often, not always, but they often will do a compulsive ritual to try to undo the obsession. They may count things, check things, read scripture, arrange things over and over and spend hours doing this. That's OCD. OCPD, or obsessive compulsive personality, these are often firstborn males that have a relative that has obsessive compulsive personality, and they come from disciplines that are backgrounds of harsh discipline. They like order and perfection. They're inflexible. They're mechanical, if you will. They're misers. They don't like to delegate responsibility to others. They're very detail oriented. I'll just do it myself. They often are unemotional, though, and hard to connect with. And they're overly conscientious about things. So you get the idea. And again, this pervasive pattern. So treatment of choice for cluster C, psychotherapy. I will say that avoidant and dependent, focusing on assertive training and self-reliance can be very beneficial. Individuals with avoidant and dependent personality can make some fairly significant gains. It's in comparison to obsessive compulsive personality or narcissism, which are much more kind of recalcitrant or difficult to treat. Individual and group therapy for cluster C can be effective. And again, pharmacotherapy is directed at the comorbidity. So summary of cluster A, paranoids are suspicious, hold grudges. They're not typically psychotic or unlawful. Schizoid or unemotional, cold, aloof, and detached. Schizotypal or have magical beliefs. They're odd and eccentric and strange, not usually paranoid unless they decompensate. Summary of cluster B is antisocial. They're impulsive and unlawful and aggressive and lack remorse. Um, Borderline are unstable, if you will. They have chaotic relationships. They fear abandonment. They tend not to be aggressive or unlawful, but they're emotional and have mood swings. Histrionic is theatrical and dramatic and seductive, but they're not tend to not have the chaos that the borderlines do. Narcissistic are the E's, as I mentioned, entitled. They lack empathy. Um, they are envious of others. They're exploitative. They occur along a spectrum from the vulnerable to the oblivious to the malignant, or even into the dark triad, as we talked about. Um, and then cluster C is the avoidance, to be separated from social anxiety. It's not to say you can't have both, but these individuals fear rejection and have kind of a low sense of who they are, if you will. Dependent, they need relationships, they're indecisive, and they fear abandonment. And then obsessive compulsive personalities, these are mechanical, rigid, perfectionistic individuals. So uh, that's the overview of um, personalities, um, and what you will see um, across the spectrum. And we're going to jump more into this now with substance, but I had to create a background in order to, I think, to create an understanding. So I'm sorry if it wasn't overly interesting. This does affect your other parts of your practice, incidentally. So, all right.
Thanks, Todd. Really interesting. I threw in a link to the chat to get to complete the survey to get your certificate. And Todd, if you could send me those slides, I can send those out. And Dr. Massey, that reminds me, if you could send me your slides from a couple weeks ago, I can send both groups out together. We do have, let's see, we have one question here I see in the chat. Where do a group such as MS-13 fit in? Like the gang members, where would they fit in terms of personality disorder?
Well, in general, and again, this is broadly speaking, and the broadly speaking nature to um, kind of gang members in general is that there's a process that where individuals need to be jumped into a gang. And for those of you that are not familiar, maybe everybody's familiar with that. Jumping in is you serve you kind of have to go through some pretty tough stuff. You may have to steal something or set something on fire, or the group members may beat you. You know, they may all put you in a circle and beat you up, or you may have to go have sex with somebody. So there's clearly a process that takes place to get into a gang to show your loyalty, and the behaviors that go along with the process um, often are in the spectrum of conduct. If it's younger, lying, cheating, stealing, running away, physical harm, killing an animal. Sometimes some gangs are so severe, depending on where they're at, they have to kill a person, right? So it really is in the sociopathic kind of realm of things. And again, I don't want everybody to think that's 100% true, but that would be the most likely kind of scenario.
Let's see here. Question from Gary. I don't think you guys can see this. It came just to me. Gary asks, he said, we saw an association with childhood sexual abuse and borderline personality disorder in our bariatric practice. Any thoughts on that?
I miss
Oh,
association between what?
association
I'm
with
sorry.
child sexual abuse and borderline personality disorder in a bariatric practice. Um, Any thoughts on those connections?
I actually do have a thought on that, interestingly enough. So let's go back to embryology a little bit to start my discussion. And I'm sorry. So if you look at neuroectoderm and development of migration of tissue, you'll find that the GI tract has some of the same chemicals and substances as the central nervous system, as well as the peripheral nervous system. And so when you talk about the mind-brain connection, not only is there psychosomatic components, but many times people that have gone through adverse childhood experiences, traumatic emotional experiences, or chaos or unpredictability, develop not only a difficulty forming normal development within their personality, but they will turn to things that have an effect on emotion, such as food, okay, and eating, again because of the developmental kind of, I believe at least partly the development where it comes from. Just like substances, they can modulate kind of the intensity of an emotion, or curtail it or reduce it. So you'll find not only there is this component of quote unquote soothing with eating or using substances that may kind of attenuate undesirable experiences for people, but it is often driven from kind of developmental experiences. So I think that's certainly a part of what to think about when it comes to this context. We'll get you the link for Twinge's studies and the book. I should have grabbed that with me. And there's some interesting reads with that I think is worth really looking at. She's done extensive work. And so this is not somebody that's taken the topic casually. She's done extensive work. And narcissism is largely misunderstood. Remember that um, we all have, to varying degrees, not all of us, but most of us have to varying degrees, narcissistic defense mechanisms that are healthy, that can help us manage stress or manage the world. It's when they become more intense or severe across the spectrum and they're more, there it is, twinge, more maladaptive, that problems can emerge. So anyway, I don't, I hope that the topic was okay today. It really was the idea of a background and then moving into talking about substance. But personality affects all, whether you're John Massey and treating someone who has pain, you got personality issues that emerge, and especially when people are in pain that they don't cope as well, or when someone has been faced with I've got diabetes and my eyes aren't working as well, or cancer, or mom and dad trying to deal with a child that's sick. So personality is a huge component, and that's what I'm trying to let everybody know, that it is really important and we can't overlook it, in my opinion.
Alex, I see you're raising your hand.
Yeah, Todd, I appreciate you talking about this. As I think of the patients who have given me the most heartburn as a clinician and made me lose the most sleep, personality always comes into it. And whether it's substances or, maladaptive management of diabetes and people getting, medical complications, or like HIV, like what led people to get into the risky behaviors, or some people like who were assaulted and that was how they got HIV. Like, what did that do to them afterward? I mean, so yeah, it's very much it's less pragmatic and like, what do I do, in the office, but just being aware of it. I appreciate you bringing this back to mind, so that because yeah, as I look back, like again, every patient where you see them on the schedule, like, oh, this is going to be a hard day. Like it's always their personality. Like they can have all the medical complexity in the world, doesn't phase me, but some people with their personality is in a bad spot or they have a decompensated personality disorder, that wrecks my day. And so being aware of that can help me manage my own emotions as I'm taking care of them.
Terrific comments. Thank you. I know we're
Yeah.
over time, so um, I,
Mm.
unless there's something else, we probably should sign off. If there are other um, comments or things to be, questions, please reach out. And I appreciate Alex's comment. It's the old idea of check yourself at the door before you go in because you want to be the best version of yourself given the uh, patient you're working with.
Yeah, thanks everybody. So yeah, we'll be back in a couple weeks. Alex will be giving the talk then on infectious comorbidities. So look forward to that one and see you guys then. Thank you.